So we are officially recording. Hi, everybody, and thank you for coming to the first fall Lunch and Learn of the Faculty and Staff Professional Development Committee offering. We are super excited to have Marguerite Goulet from the RN to BSN program presenting to us today on genetics and genomics in nursing education. And while it does have a focus on nursing education, it does have applicable concepts for some of our gen ed and elective courses. So welcome everybody that is not in the School of Nursing that's joining us today, or anybody that watches this once we get it up. A little bit of background for Marguerite, for anyone that doesn't know her. She is a cancer genetic counselor and has been for the last 13 years for a large community hospital system. She's credentialed as an advanced practice nurse in genetics by the Genetic Nurse Credentialing Commission and is board certified as an advanced genetics nurse by ANCC as well. She serves on the ANCC Content Expert Panel in Genetics and worked with a team to develop the portfolio for the Advanced Genetic Nurse Credential for ANCC. So this is really her wheelhouse, and we are super excited to have her presenting to us today. So Marguerite, I am going to hand it over to you.
Okay, thanks. Hang on, let me get this out of the way. Oops. All right. Okay. But even though this program is entitled Genetics and Genomics in Nursing Education, genetics and genomics plays a role in the development of all diseases, and diseases may run in families. So this topic may have personal meaning to you as well. These definitions are from the American Nurses Association and the International Society of Nurses and Genetics Scope and Standards of Practice for Genetics and Genomics Nursing. Genetics and genomics nursing has traditionally involved the care of people with single gene disorders or chromosomal disorders, such as cystic fibrosis, Huntington's disease, and Down syndrome. However, even single gene disorders are modified by other genes in the environment, and that broadens the nursing specialty to include genomics nursing. And that includes health issues related to multiple genes in the human genome, including interactions with each other and the environment, and the influence of cultural and psychosocial factors. I have some disclaimers. I have no commercial interest to any testing lab, and the complexity and broadness of this topic is almost overwhelming, because one can talk for 2 hours about the genetics of breast cancer. So this is just an overview for the short time frame. And there are daily genetic and genomic advances with predisposition testing, tests available, and how to use those test results for treatments. And I can think of just the times that in the last 13 years, the different things I've seen with advances, and it's coming in almost daily. New information to guide treatment has been really significant. We now have whole genome sequencing, we have panel tests, and these are all relatively new. The other disclaimer is I might violate some PowerPoint principles, but I will also I'll try to define all of my acronyms that I'll use, and genetics is full of them. So we want to discuss the importance of genetics and genomics in nursing and in education in general, identify diverse practice settings where nurses need knowledge. Nurses and really even other healthcare professionals need knowledge to identify, refer, support, educate, and care for people affected by or at risk for conditions or diseases with a genetic component, and to create ideas for future integration of genetics and genomics into nursing curriculum, but also for other courses as well. So why the focus on genetics and genomics in nursing education? And you can see from these Time magazine covers, this is what patients and the general public reads. So Genetics, the Future is Now is on the left-hand side, and the Angelina Effect You know, when Angelina came out about her BRCA mutation, I can tell you physicians' offices and cancer genetics programs were inundated with calls from people wanting to understand their risk and also questioning their need for genetic testing. Also, this other magazine cover shows you in the boxes, these are all diseases that have a genetic or genomic component. And I use this in EPI class when I discuss genetic testing as a screening test. So there's an increasing recognition of the influence of genetics and genomics and heredity in all clinical settings. And when we hear the terms of personalized or precision medicine or healthcare, we know that the environment, genetics, and lifestyle influence the risk of disease. Now, at this point, we can't easily change our genetics, but we may be able to change other components to modify the risk of disease development. With that caveat, I will tell you yesterday and this is what I mean by daily advances, there are two companies that was reported in the Wall Street Journal that are working together on a gene editing tool. So what do you think is the most powerful and overlooked genetic tool? This case study, and this is an actual case study, illustrates that personal and family history is the most powerful genetic tool available. And I know Jill has used this case study in Patho because it illustrates several important points. This was a patient I actually saw in my clinical practice. A 36-year-old female pregnant with her first child. She had a normal pregnancy until approximately 28 weeks gestation when a breast lump developed. Her OB waited several weeks and tried her with several antibiotics, thinking she might have had mastitis, but there were no results. So then she was referred to a surgeon. What did the surgeon's office learn in taking her history? Her mother had breast cancer at age 45 and died with a swollen abdomen at age 50. Now, women typically don't get a swollen abdomen with breast cancer. She also was an only child, so not a big family. And she was of Eastern Central European Jewish heritage, or Ashkenazi. Ashkenazi Jewish individuals have a 1 in 40 or 2.5% carrier rate of having a BRCA gene mutation. And to put that into perspective, the general population risk is 1 in 400 to 1 in 800. She had a very small family, and not unlike many Ashkenazi Jewish individuals, there was minimal third-generation family history available due to the Holocaust. So the surgeon did a breast biopsy, and she was diagnosed with a triple negative invasive breast cancer during her pregnancy. Now, triple negative meaning she was negative for estrogen receptors, negative for progesterone receptors, and negative for the HER2/neu protein. And HER2/neu stands for human epidermal growth factor, and it's a protein that appears on the surface of all breast cells. But 20% of patients with HER2 positive breast cancers have a gene mutation that makes an increase in the HER2 protein. And so we actually have treatments that are effective that target that HER2 overexpression. She underwent a mastectomy with a lymph node dissection, and she opted to do a contralateral simple mastectomy and reconstruction on the other side. She did have one lymph node positive for cancer. And she delivered her daughter, underwent chemotherapy, and then she came to see me for cancer genetic counseling and testing. In individuals of Eastern Central European Jewish ancestry, we start testing for 3 common mutations, 2 in BRCA1 and 1 in BRCA2. And she did indeed test positive for a BRCA1 gene mutation. They tried to do a laparoscopically assisted vaginal hysterectomy on her, but ran into difficulty, so she ended up having a total abdominal hysterectomy and removal of her tubes and ovaries. She decided that because she really didn't want more than one child, and she was concerned that she thought perhaps her mom may have had ovarian cancer. And she went to Israel, brought back the medical records. She and I sat down, and we did later learn from translation from Hebrew to English and medical terminology that her mom did indeed die of ovarian cancer. So what are case study clues or red flags? Well, first, she had a personal history of breast cancer at a young age and during pregnancy. Breast cancer is common. 1 out of every 8 women will develop breast cancer in their lifetime. And the average age of development of a sporadic breast cancer is at age 62. But premenopausal breast cancer is somewhat suspicious. Secondly, she got breast cancer in her pregnancy, which is also suspicious for a BRCA mutation. She had a triple negative breast cancer. And triple negative breast cancers are more common in BRCA mutations. In fact, so common that most insurance companies will pay for genetic testing for women under the age of 60 with a triple negative breast cancer in the absence of family history. Other clue was her ethnicity. The fact that her mom also had a premenopausal breast cancer and then a confirmed ovarian cancer. The other thing was she had a limited family history. She was the only child. And that's actually looked at by insurance companies. Very small families and family histories are looked at. So there's her family tree. And you can see that she had no maternal cousins at all. Her maternal aunt died of heart problems at 53. And she had very little third-generational family history. Interestingly, in this family, her husband was also Ashkenazi Jewish, and his mom had breast cancer in her 50s. So because they had a daughter, he wanted to be tested for the 3 common Jewish founder mutations, and he tested negative, fortunately. Because I have seen Jewish families where they have mutations coming from both sides of the family. So history is the key, and it's crucial to emphasize to nurses, nursing students, other healthcare professionals, and the public that history is crucial. It's crucial to know one's own family history, personal history, and also physical examination is very important as well. And by that I mean there's some hereditary syndromes that have physical findings that you can that may make you more suspicious. The other thing is the paternal and maternal family history needs to be looked at. And I have a lot of patients in my experience that think that you can inherit a damaged copy of a BRCA gene or any gene from the father's side of the family. And you can inherit it just as easily from the father's side as from the mother's side. And in fact, from the father's side, the family history may not be as striking. It's important to say, what are the major health conditions in a family? What ages did people die? What was the cause of death? And also to know the ethnicity within a family as well. So family history is an important assessment tool. We have shared factors, genes, environment, and lifestyle. But to show that disease is multifactorial, you can really see that with identical twins. Identical twins have the same genes, but they may have very different lifestyles and environments. And I saw a patient in my practice who was an identical twin, and she developed breast cancer in her 40s. And they were in their 50s now, but her other identical twin had not developed breast cancer, and they lived apart from each other. So family history is also accessible, it's non-invasive, it's inexpensive to obtain, and it may influence disease management and prevention. And I think we really see this now in type 2 diabetes. We're screening families who have a strong family history of type 2 diabetes with hemoglobin A1C. Positive family history increases the risk two to tenfold over the general population risk of disease development. And positive family history may prompt lifestyle changes and increased screening, or also referral to genetic counseling and genetic testing if appropriate. So when assessing a family history, it's important to ask questions. And you may have to ask these questions in multiple ways. Do you have diseases or conditions that run in your family? Have there been problems with pregnancy and fertility or birth defects in your family? Have any of your family members died or become sick at an early age? What's your ethnicity? Where did your ancestors come from? Where do your people come from? Are there any traits or non-medical conditions that run in your family? And, you could be with a family and notice that there's a lot of the family members that have learning disabilities. So paying attention to what you're seeing and what you're hearing. It's very important, I think, too, to pay attention to what family members are saying. And you may be taking care of someone who is in for a cardiac problem, but another family member may say, gee, this is unusual. Everybody else in the family dies of cancer. Well, tell me more about that. So pursuing a statement like that. And as a result of obtaining family history information, and we'll talk a little bit more about that in a minute, these are general adult guidelines for referral to genetic counseling and possibly testing. A personal or family history of suspected genetic condition or chromosomal abnormality, for example, cystic fibrosis or Huntington's disease. A personal or family history of common conditions in unusual presentations. For example, sudden cardiac arrest in a young person. A person or family history suspicious of a hereditary cancer syndrome. Early age of onset, like our case study showed. Cancer clustering. So that means cancer clusters in the same family. Multiple primary cancers. And you can see individuals with 3, 4. I've seen individuals with 5 different types of cancer. Bilateral or paired organs. So bilateral breast cancer or breast and ovarian cancer. Male breast cancer. Rare cancers or tumors, and a large amount of colon polyps. And also if there's an associated ethnicity, and sudden premature death in an apparently healthy person, either by drowning, simple car accidents, suspicious deaths. And hypertrophic cardiomyopathy is the cause of at least 1 out of every 3 sudden deaths in young athletes. So some general pediatric guidelines for genetic counseling referral is abnormal newborn screening test. And in New York, we are currently screening for approximately 58 tests. In my state, it's about 46. A really good website to get information out to families about newborn screening tests is the Baby's First test. But also other guidelines are 1 or more major malformations in an organ system, so heart defects, neural tube defects, those types of things, abnormalities in growth, short stature, developmental delays. And years ago, when a child would have multiple physical or developmental delays, they would do, targeted gene testing. But now, and maybe it would come back negative, but now we have whole genome sequencing, and we're getting better at being able to identify conditions in children. One in about every 6 children with a developmental delay may have an underlying genetic cause. Blindness or deafness, and you can see this with ocular albinism. The presence of a known or suspected genetic disorder or chromosomal abnormality, a family history of a known or suspected disorder like Marfan syndrome, or a suspicious death in a young person. A young person died in their sleep. It could be long QT3 syndrome. Some general reproductive guidelines for possible referral would be advanced maternal age. And even women over 35 get treated a bit differently in their prenatal care because they may undergo increased screening, ultrasound for growth and non-stress tests. And also anyone who has an abnormal result on the maternal screen. Personal or family history of a known genetic disorder or birth defect or chromosomal abnormality. Ethnic background associated with genetic predispositions. So, for example, sickle cell in African Americans or cystic fibrosis is more common in Caucasians. Exposure to a teratogen like irradiation, or a maternal medical condition that can impact fetal development like type 1 diabetes or a maternal heart condition. 2 or more pregnancy losses or stillbirths, and consanguinity or other concern of chromosomal abnormality. And being from the same kinship can increase the risk of some type of genetic disorder. And in fact, there has been a lot of studies done in the Amish population because of that. So the role nurses and other healthcare professionals play is in patient assessment, looking at features in the individual and the family. For example, if you're someone who's working in an endoscopy unit and a patient comes in with a colon that's carpeted with polyps, right then and there, that's an indicator that there's most likely a hereditary cancer syndrome going on in that individual. And there's a hereditary cancer syndrome called familial adenomatous polyposis that you can see hundreds and thousands of polyps in very young individuals. Taking family histories. And there are many tools available for taking family histories. I'm going to show you on the next slide what some of those are. But even a lot of the testing labs will have tools for taking family histories. Observing families, answering questions, relationship building, providing information and education and support. It is crucial in whatever practice setting a healthcare professional is working in. It's important to know where the genetic professionals are close to your practice setting. So either providing a brochure or some information about websites. In the hospital system that I was employed at, we had our cancer genetics programs all over the place. And patients and family members would pick them up in waiting rooms and things like that. This slide shows some American Society of Human Genetics resources for family history. Nurses can take histories using online resources. There's apps. There's one that's called Family Search. An institution that our institution was affiliated with used to have patient portals throughout the hospital. And this was a really neat thing because they were used for education, but they were also used to ascertain family history information. And that information would go directly to genetics, and they would determine whether, based on the information they got, whether they needed to contact the individual or whether they were assessed at low risk, intermediate risk, or high risk. The Family Health Portrait tool is also a great resource because it allows you to go online and actually do your own pedigree. Another important piece of information, though, here on family history is histories can change. And this is especially true if you're working in a physician's office or any place where you're seeing a patient routinely. It's very important to review personal and family history because over time, diagnoses may occur in the family, and that could change and impact the risk assessment. It may increase the likelihood of a hereditary predisposition, such as cancer or cardiovascular conditions. So as this family tree shows, the woman that has the arrow pointing to her had a mom who died of colon cancer at age 50. So just based on that initial history alone, she and her siblings should start screening for colon cancer. If her mom died at age 50 and was diagnosed at age 50, she should start screening 10 years earlier than the earliest diagnosed person in the family. So instead of waiting till age 50 to have a baseline colonoscopy, have one at age 40. 2 years later, this is what the family history may look like. So now she has a sister with endometrial cancer at age 44, and that in itself is unusual because endometrial cancer typically occurs later on in life. You can see it in postmenopausally obese women and also people who women who've had excessive estrogen exposure. The other thing is she also has a brother now who has colon polyps in addition to the maternal family history. So the person that you may be seeing may be unaffected, but the best person to begin genetic testing with and referral to genetics would be her sister with endometrial cancer, because you want to start testing with the person who's most likely to test positive, and that's the person who's affected with cancer. Even if her sister undergoes genetic testing and tests negative, she may still have to do increased screening based upon this family history. So clinical practice settings where you can encounter patients with genetic or genomic conditions, there are many, and these are just a few of them. In the prenatal setting, the perinatal setting, the newborn setting, developmental and autism spectrum disorders are very common. 1 out of 68 kids in the US is diagnosed on the autism spectrum. So they're now doing genetic testing for all children diagnosed on the autism spectrum. And somewhere in the neighborhood of 10 to 20% of those will have a positive test result. And that's valuable information for the family. Also, metabolic disorders. One of the more common ones is celiac disease. So that can be tested for to see who in the family carries the gene mutation so that you can make the necessary dietary changes. You see this a lot with the cancer testing. It's not only cancer predisposition testing, it's cancer tumor testing. It's genetic testing to determine Oncotype DX testing will test a recurrence score for these people that fall. It's undetermined whether they would benefit from chemo. They can do a 30 gene assay to determine what the recurrence score is, and based on that score, they will may decide whether to give chemo or not give chemo. Also, PARP inhibitors or poly-ADP ribose polymerase inhibitors are used in BRCA-positive patients to treat ovarian cancer because they target both the cancer and the defective DNA repair in BRCA1 and 2. And actually in the cardiovascular setting and in pharmacogenetics and pharmacogenomics. And I'm going to drill down on a couple of these. So I talked about mentioned pathology reports. So if you're working in a doctor's office or in a hospital, you may see something on a pathology report. And this is an example of what you can see. And there's the most common hereditary colon cancer syndrome, and it's actually colon and in the endometrial in women, is called Lynch syndrome or HNPCC or hereditary non-polyposis colorectal cancer. And that's the most common colon cancer syndrome. So what we can now do, and a lot of hospitals are doing this because it can be done in a pathology department, is determine whether that colon cancer or that endometrial cancer is just a sporadic cancer or could it be a hereditary cancer. And in sporadic cancers, you normally see the 4 protein products of the 4 genes present in sporadic colon cancers. But if any of those protein products are missing or absent, depending upon which protein product it is, it can indicate a mutation or something that's called methylation. So this will help direct gene testing by predicting the likely gene involved. For example, if MSH2 and MSH6 are absent, you would start doing testing for MSH2 first and then MSH6. And it'll help direct gene testing, but it also can impact chemotherapy because 5-FU chemo, which is one of the drugs used to treat colorectal cancer, is not as effective in Lynch syndrome. Also, pharmacogenomics and pharmacogenetics. There are some, and we're still on the tip of the iceberg when it comes to the use of genetic testing with drugs. And this definition is from the National Human Genome Research Institute. Pharmacogenetics and genomics is a branch of pharmacology using DNA and amino acid sequence data for drug development, testing, and response. It's really all about the right dose at the right drug and at the right time, and it's based on the patient's genetic characteristics. Here's just some of the examples. Using EGFR expression or epidermal growth factor receptor status for laryngeal cancer or for lung cancer. And you've probably already seen some commercials about this for non-small cell lung cancer using certain drugs. That if you have this, a test positive for EGFR, then they'll customize your cancer treatment. We already talked a little bit about HER2 new in breast cancer using trastuzumab or Herceptin or a like drug for people who overexpress HER2 new. PARP inhibitors for ovarian cancer. And you can also see in individuals, this is much more common, is with Coumadin and Plavix. You know, there's variants in certain genes that can reduce the enzymatic activity or decrease the effectiveness of platelet inhibition with Plavix. And in fact, 1 out of 4, or 27% of the population, has a non-metabolizer allele for CPY2C19. So sometimes they're doing genetic testing before they start somebody on Plavix. Nurses or really any healthcare professional may encounter patients who are recently diagnosed with a disease or condition, which may be due to a genetic predisposition, recently tested positive for a hereditary condition in or out of the hospital, who want to know how to decrease their risk with diet, exercise, lifestyle changes, whose family member recently tested positive, negative, or there's a third possible test result called a variant of uncertain significance, and that's actually an ambiguous result with genetic testing and difficult to interpret, basically. Or someone who's undergoing increased screening, a procedure or a surgery due to a genetic predisposition. And Facing Our Risk of Cancer Empowered or FORCE coined a new term, and it's called a previvor. And that's a person who is a survivor of a predisposition to cancer but does not have the disease yet. So you may see a patient who's coming in for a surgery, and let's say it's a mastectomy or oophorectomy, and you may think that person has cancer, but they may not have cancer, and they may be a previvor. Or you may see someone coming in for a pacemaker or implantable cardioverter or defibrillator for hypertrophic cardiomyopathy or long QT syndrome. You may encounter patients who have medication questions due to the genetic test result, who are deciding to have genetic counseling, who question about genetic counseling or genetic testing privacy, duty to warn, the ethical aspects.
They want it. You want it's about the patient. Okay. Don't ever say
Can everybody please mute their mics, please?
So those patients have all that needs. Okay. So patient will love.
Who question about genetic counseling or genetic testing privacy and duty to warn. Patients who question why they're being referred to genetics or who ordered a certain medication based on a genetic test result. If they have long QT, they may be on beta blockers, or they may have to avoid drugs which prolong the QT. Or, and this I've seen in my practice come in with a direct-to-consumer or genetic test result and need more information. 23andMe, you can now, you can order, you've always been able to order 23andMe test kits online, but now they're available at CVS. All of the ethical principles certainly come into play when we're talking about genetic testing. And we actually talk about this in our genetic testing debate in ethics. Issues of autonomy in testing in children. Other people in the family may not want to know genetic test results. All different kinds of ethical dilemmas, confidentiality versus duty to warn at-risk family members. Autonomy related to patients' wishes regarding testing, disclosure of results, beneficence and non-maleficence, and veracity and justice with respect to relatives. Justice comes up a lot because not everybody has the ability to pay for costly genetic testing or even costly genetic counseling. And legally, confidentiality and duty to warn others. So generally, a physician or therapist has a duty to warn if they have a professional relationship with the person who may cause harm or the potential victim. And the person is, the risk is identifiable and harm is foreseeable and serious. And there was a case where a physician was taking care of two siblings, one of which had tested positive for an APC mutation for that hereditary colon cancer syndrome called FAP, where you have hundreds and thousands of polyps. The lifetime risk for an individual to develop colorectal cancer is about 100%. And one of the siblings tested positive and didn't want the other one to know. And the physician had a duty to warn because he was involved in the care of both of those patients, and the risk was identifiable, foreseeable, and serious. So genetics and genomics creates a host of ethical and legal issues. And to kind of just wrap up, there are essential nursing competencies for genetics and genomics. And genetic and genomic competencies are integral to all RN practice, regardless of academic preparation, practice setting, role, or specialty. And those that website gives you access to those genetic competencies. So genetics and genomics in the BSN curriculum, it could be a single course. And we have a medical genetics course. And it also could be integrated into multiple courses, and we have some of that occurring already within our curriculum. When I revised the DQ, sample DQ questions, I put a response in there on pharmacogenetics for the students to read. I know Jill uses examples in patho for family history and ethnicity, health assessment, family history, and also certainly in ethics for our genetic testing debate. And we talk about policy issues and legal issues like GINA, the Genetic Information Non-Discrimination Act. Use of case studies or storytelling is a very powerful way to communicate information to students about genetics and genomics. So basically integrating across the curriculum in a number of places, and incorporating these concepts into biology understanding, risk assessment, health of individuals, families and populations, into evidence-based practice as well. So some resources for faculty. Cincinnati Children's Hospital has some great modules that you can do online. And then the Genetics Genomics Competency Center. Genetics Home Reference is a great resource, and I use that a lot in my replies to students who are talking about genetic testing or genetic illnesses. The International Society of Nurses and Genetics, and ISONG has usually 3 to 4 webinars a year where you can get contact hours through the University of Pittsburgh. There is a cost associated with those if you just want to learn more. And then there's a National Human Genome Research Institute. They have a talking glossary. And out of the UK, Telling Stories, Understanding Real Life Genetics is a part I'm part of the Common Hour Committee, and in October is going to be a Common Hour program called BRCA and Beyond, a discussion about breast cancer prevention. And it's unfortunately on the same date that we're having Julie's doing her presentation on grade mark, but it's from 12:30 to 2 in the Oaken Theater, and it's going to feature Caitlin Brodnick, who's a Previvor, a BRCA-positive patient. She is a wonderful speaker and a comedian, and actually one of our nursing students who is a breast cancer survivor will also be speaking as well. And I wanted to put in a plug for ANCC certification for the AGNBC for any nurses who are working either in a high-risk breast clinic or with high-risk colon cancer patients. They may be eligible for certification as an AGNBC. It's for advanced practice nurses and master's prepared nurses. Any questions at all?
Marguerite, that was a good presentation. You had mentioned some resources that are available where we can go in and fill them out on our genetic histories. I'm thinking about the privacy component of that. Obviously, if I can go in and look for somebody else in my family or family history, then that probably isn't too private, right?
Yeah, well, that's the whole thing, Becky. I mean, yeah. If you go in and have genetic testing with electronic medical records, your test results are available on the electronic medical record.
Right.
So,
yeah.
Now there is legislation protecting individuals against, health legislation protecting individuals against genetic discrimination. But there's nothing to protect you with life, disability, long-term care insurance. So yeah, that is a very sticky, situation. And with social media, employers are getting Facebook accounts and looking at people. They may be, even though it's not legal, they may be screening employees based on information like that. So yeah,
it would be interesting to know if the insurance companies did go online, look at these things, and then just based on family history, increase the prices for premiums or not accept them based upon those.
Well, actually, Becky, in the whole time I was doing cancer genetic counseling, I never once had an insurance company ask, even though they paid for the test result, I never once had one ask me about the test result. And the reason for that is insurance companies, hire actuaries, and they, what they do is they look at risk. And so many of these genetic predispositions cause such an increased likelihood. They realize it's cheaper and smarter for them to pay. I know that sounds crude, but it is cheaper and smarter for them to pay for testing than to pay for a diagnosis. So they usually don't know, but and with the Affordable Care Act, there's certain provisions within the Affordable Care Act with which, they eliminated the predisposition or what do I want to say, pre-existing clause with that.
I was thinking more of like the long-term care and the life insurance.
Well, and when I was doing counseling with people, especially when they were trying to test children, and there are certain hereditary cancer syndromes where you may want to test children because cancers can occur at very young ages. And I would always tell those people to set up the life insurance first and that kind of thing. And same thing with long-term care insurance. If an older person wanted to undergo testing, we would tell them before they might get tested, but we wouldn't release their test results to them until they set up their insurance. Mm-hmm.
Marguerite, thank you for your presentation. I just learned so much. And just an aside, I also learned something new too. I was at a meeting on Tuesday for the AALNC, which is the Legal Nurse Consulting Group, and we had an expert speak to us then. And she was representing families who do seek lawsuits. And in regards to neurological injuries, childbirth and all that, we're one of 2 states across the United States that has a form that families have to sign. It's called the NICA, Neurological Injury Compensation Association. And for the most part, in order to determine if families are eligible for this, we in the state of Florida have 2 placenta pathologists who do nothing but look at placentas to determine if there's a neurological injury and to also identify if that injury was pre-existing or did it happen at the time of birth. The insurance companies here in Florida pretty much rule the health care along with the AMA, but I had never heard of a, I have to write it down, placenta pathologist, to look at. And so when the child is born, if there's any sort of idea at that time when they're doing their APGAR scales and their assessment and everything else, if they do determine that there might be something wrong with that child, that there might be a neurological injury, they automatically keep the placenta so that the pathologist within the state can look at it to determine if the insurance company has to pay out or whatever. And what they do to families, and I wasn't aware of this, is that they offer a lump sum fee of like $100,000. And if you accept the $100,000, that precludes you from suing for $5 million down the road if they find out that the baby was dropped in the bucket or across the room, or it was left in utero too long, or they look at the fetal tracings too. But this whole field is just absolutely remarkable. So thank you for your presentation and more enlightenment.
Right. Well, one other thing I wanted to add that I had forgotten to mention is we talked a little bit about, and we've all heard in the news about young athletes that, drop dead on the soccer field or what. And a lot of states have in place whenever a young person dies, when they do, when that body goes, they actually try to get genetic material for later testing. Because again, the person who's affected is the one you want to start testing with. So if you see a young person die suddenly like that, that's very unexpected. I know in the state of Ohio, coroners will take samples so that even though the insurance company won't pay for testing, at least the family may be able, and in family, you want answers as to why, and I've seen 9-year-olds, where not me personally, we used to refer them for cardiovascular genetics, but the hospital system I was affiliated with had a cardiovascular genetic counselor, and she used to see all the families with cardiovascular genetic conditions. And they do that in a lot of states now so that there's a blood or some kind of DNA that they can run testing on to hopefully find a reason why that person died, which I think is very important to families to want to understand, why did my child die at such a young age?
That's also a topic in Patho, is the long QT and some discussion about what are the ethics behind genetic testing, and do all athletes, all high school athletes, should that be included as part of their physical in order to participate in sports? I believe it's in the UK that is something, not the genetic testing necessarily, but some sort of an EKG or some sort of cardiac testing to see if there is a prolonged QT on the EKG. But it's an interesting topic. It doesn't always come up in every session, but somebody, generally they'll mention it, like that's interesting, and why don't we do it here? And if you think about the scope of doing that in the United States, it's certainly, if it's somebody in the family. And I personally have a friend that her daughter passed from it, and the woman has an AICD, and 2 weeks after her daughter passed, her brother was in the entrance to the hospital, thankfully, and went down as a result of that. Now he has an AICD as well. So
Right.
It's really more prevalent than we think.
It really is. And these families are so striking. I mean, when you see the deaths, and that's why genetic testing can be so powerful in these families, because you can identify who carries the mutation, who's at increased risk, and who doesn't.
I'd like to add something to what Becky said about confidentiality. Even the over-the-counter genetic tests have confidentiality forms attached to them. Mm-hmm. And they ask you what you want done with your sample. Can they use it for research? Do you want it kept in case you want to come back and relook at it? Or do you want it destroyed? So I thought that was very interesting. And then just another piece of out there information. I read on my Twitter feed this morning that Aetna will now pay for a iWatch if you allow them to have access to all of your healthcare data.
Interesting.
And of course, then they want to be able to monitor you in real time.
Right. Well, in Barbara, also, there was a company called Navigenics that used to do the same thing as 23andMe, and they were bought by another company. And a lot of the question comes from what happens to all that genetic information from the previous company? You know, what do they do with that? So now most commercial labs, and it's actually due to the state of New York that the sample, there's a law in the state of New York that the sample has to be destroyed after 60 days. So most testing labs follow that. But, you know, in research, we did a lot of DNA banking so that if individuals test negative for something, then but newer tests and newer technologies are always coming out that they may have their blood banked, a DNA bank somewhere, so that if some new test comes out, then they may be, if the family wants to agree to pay for it, the person's deceased, then further testing can be done. Any other questions?
Marguerite, it's Cheryl. Could you maybe forward us in an email that slide that had the resources with the links for faculty? It was interesting. I see that this is being recorded, but you know, just that slide.
Sure.
With that information, thank you.
Sure.
It was excellent. Thank you so much.
Thanks. Well, thank you all. I know this is a busy time for everybody, so I know that you're probably all need to skedaddle and grade and do degree plans and everything else. So,
are there any more questions from Marguerite? We have just a couple minutes left.
And Marguerite, it's Lori. Just so you know, we may be able to move the presentation that we're doing on the 20th, because I think the breast cancer presentation is incredibly relevant, especially in a predominantly female faculty and with our students as well. So I'll see if we can maybe move that time a little bit to accommodate that as well. So I know there's probably some great interest in that. So
that would be great. And I can tell you, Lori, I've heard Caitlin and the student, I think you may even have the student now that she'll be graduating actually next term. So she's agreed to drive up, and it's just amazing. When I was on a conference call with these two, the energy and the passion from these two, it's going to be a great presentation. So I'm hoping that we can get the Zoom issues fixed and the recording issues fixed on Campus End. So Elizabeth Zofa's working on that. So hopefully we'll be able to have a Zoom link that works and it recorded as well.
And I'm happy to work with them to set that up as well, because we did that for a presentation in Oakham last year, and so it is possible.
Yeah, we were on Becky. What Oh, it was the one on, wasn't it violence on campus or something? And we were all on that call and it never happened. You know, we never got Zoom access.
Yeah, it turns out I think that she had gotten really busy trying to organize them that she was never able to start it. I think that's where the problem had come in.
Okay. Yeah, I've been working with Elizabeth Zofa, and she's actually on medical leave right now, but due to come back she's due to come back October the 7th. So hopefully everything will be in place by then. But I'll let you know, Lori, if you can help, because I don't want that presentation not to be recorded or be available on Zoom. It's too important a topic.
No, I agree. And I think since we have the ability to upload it to a YouTube channel and make it available, we certainly know how to help resource that for others. So I'm happy to help. Our committee's happy to help with that as we can.
Okay. And we would just have to get approval from Caitlin. I'm sure she would. She's got stuff all over YouTube as well as Sean. So.
All right. Well, Marguerite, thank you so much. What an incredibly informative presentation. I think we all learned a ton today and are going to probably go home and ask a couple more questions of our own family members. So thank you. Thank you so much. And as soon as we get the blessing from YouTube, I will have this up and posted on behalf of the Faculty and Staff Professional Development Committee for everybody to see forever.
Thank you.
Thank you.
Thank you.
Thank you, Marguerite.